Questions later.
Thank you, Dr. Murphy, for that great talk. At this point, I'd like to invite all of our speakers, Dr. Gordon, Dr. Martin, Dr. Murphy, up to our panel up here. That way, our audience has been patient, waiting to ask questions, can do so at that time, so we can all sort of great dialogue with all the fantastic information we've had so far.
So I know this is a fairly small room and we can probably hear you guys, but I'll take this microphone around. It's wireless. In case you guys have questions, I would give it to you, and then if it's directed at anyone in particular or the whole panel, just let them know, and then they can use the mic there. Anybody have questions?
Hi, so you were implying if the district money stops coming in, then we can't have as much comprehensive care in the integrated clinics?
Well, right now we're in a extension year with district. Kind of rumor on the street is that it's going to be renewed. If it's renewed, that's great, because that allows us to kind of tweak some of our existing measures and kind of move towards increased funding of our behavioral health. When we got into it, we knew it was going to be very, very busy and very valuable, but I think totally, as you can see from our original estimate there, 0.5 FTEs per site, we vastly underestimated the demand. So with the renewal, it will allow us to push more funds into expanding that program dramatically. So I'm thinking that the glass is not half full, it's 99% full. Hopefully. We'll see.
Dr. Murphy, this is the first time I've heard anything about legal involvement in the medical arena, and I'm very curious about that. I'm wondering how you might see that working operationally, or if there's any indication about that at this point.
Yeah, so it's actually been pretty well defined. We've been working on it for the last 18 months, and it has been an uphill battle. Getting physicians to agree that there should be attorneys associated with the clinics has been a completely alien concept to everyone. The adversarial relationship that we've had between these two professions over time is a big gulf to bridge. However, what we're going to be doing is in fact surveying the patients that come into the clinics with very simple, that have been well validated and well vetted questionnaires to identify some of the very simple things. And it turns out some of the questions on the questionnaires are: have you or one of your family members been in the emergency room 3 or more times in the last 6 months? Have you lost your job in the last 6 months? You got a high school education? Have you been a victim of domestic abuse? So there's 6 to 10 very simple questions that trigger off, yes, we need to get our community health worker or our social worker more involved. Once there's a determination that this is a civil legal need, then it will actually go to the paralegal or the attorney, who will then either set up a FaceTime or a real face-to-face meeting with the patient, or they'll do a telephone consult, etc. Fortunately, a lot of this can be done with telemedicine. The timing is probably really pretty good right now. Harvey is going to impart essentially a rolling disaster with regards to people that can't afford to fix up their houses. And it doesn't take long before you've got 2 or 3 small kids at home with asthma, mold in the house, kids in the emergency room multiple times. I can send a social worker to the house, and the social worker will say, move, that's not happening. Or stop being poor, that's not happening. But if we send the attorney there, we sue the landlord. It sounds like a rather brash statement, but it probably wouldn't come to that if I know that we could write letters back encouraging the landlord to clean up the mess.
How do you see this being essential to the medical health care scenario?
Well, one of the first sites where we put in these, including a medical partnership, is we have one of only 3 comprehensive sickle cell clinics in the country. We have 500 patients that are registered right now. This is a population, no pun intended, that literally lives from crisis to crisis, not only do they live from physical crisis to physical crisis, from social crisis to social crisis. So they can't work, they can't keep a job, they can't get health benefits, they're wrongfully dismissed, they lose everything, they can't find the medications. So we can do what we need to do on the legal side of things to make sure that they can make it to the clinic, that their car hasn't been wrongfully repossessed, that whatever benefits that they have can be continued and maintained. So we can do a very good job as physical health providers. Behavioral health and the legal health has to come from really innovative new projects. So, and these folks all have behavioral health problems.
Hey, Scott, just full disclosure, I'm also with UT, and I appreciated what Dr. Murphy was saying about the district innate funding and how without that it would be very challenging for us to provide comprehensive care.
I've been working on my goal.
Yeah. So I was hoping that perhaps our friends from Texas Children's and also with Legacy could maybe comment on some of the struggles to sort of keep things solvent with their different health models.
Yes, I mean, again, I think you heard kind of how we are doing it, which I think is, we're very privileged and, I feel very lucky that thus far we are able to do it through using the per member per month money that we receive from the health plan. Now, of course, the challenge is I can only take someone who has the Texas Children's Health Plan. So, that is a little bit against my treat everybody I want to see them all, but as long as they have the health plan, we are able to provide that behavioral health care as part of their per member per month fee. I don't know if that answers your question, but
If they have that health plan, are they guaranteed access to a provider?
well, yes, absolutely. Anybody who has the health plan can come to our clinic.
So with us, we're a federally qualified health center, so we're reimbursed kind of at higher rates with Medicaid, for Medicaid patients, and that's where our funding comes from.
And you and I have talked about this a little bit, but I work at Legacy as well. So we, and I was talking to Dr. Murphy about this before, as an FQHC, we did not get any of the District 1115 waiver money, and so one of my frustrations and wanting to do more integrated behavioral health care for years, I wish that we were where we are now 5 years ago, is people think that because we're an FQHC, oh, you get all this like federal grant money and like money's raining down on you. Well, the truth is that over 85% of our revenue comes from seeing patients. So yeah, we get an enhanced rate for Medicaid and Medicare, but we get, the usual rate for insurance, and then we see people on sliding scale down to $10, $15, $20 a visit, which we're losing money on, right? So anytime that we want to do these things with team members who are not revenue generating team members, we have to be really thoughtful about, the plus and minus columns. And so it's been really hard to get behavioral health consultants in our clinics to pay for themselves. We know that it works, we know that it's important, but if it's not somebody there with a full schedule every day seeing patients, it's really a risk. And so we've had to be really smart about that. And we were talking earlier about Texas being a bit behind the game on moving to value-based care, and so we're kind of in this limbo of still needing to do volume, but we need to show the outcomes, but we're not getting paid for the outcomes yet, and we're going to have this transition period where it's really tricky.
Hi, we are from Galveston County, y'all's southern counterparts, and Mel. This is Mel, and she actually runs an integrated behavioral health program at St. Vincent's House, which is a free clinic, not an FQHC, so she doesn't have any Medicaid revenue. It's all grant funded. And one of the questions that I have as her development director and the grant person is, what kind of outcomes do you have that are meaningful, especially for those visits that are, I think you call them the in-time consults, that may not result in someone coming back for regular traditional kinds of counseling, but they're pretty much one-time contacts with the families or the child. How do you guys capture that and make it meaningful as an outcome?
Well, if I can start with that, fortunately, we have the School of Biomedical Informatics and School of Public Health attached to University of Texas McGovern Medical School. We are, as we are piloting these projects going forward, we also recognize that the anecdotes don't sell. I mean, they're great, and everybody loves it. Everyone in the room here understands how important the stories are, because the stories reflect real people. But the payers don't care. They want to see the data. So we're looking at very simple data sets and measures moving forward for the patient's pre-intervention, post-intervention. How many times were you in the emergency room? How many times were you readmitted to the hospital? How many days of school did the kid miss? Emory has some amazing figures on these interventions. So they followed 250 children for a couple of years. That 250 kid cohort missed 2,000 plus days of school. After intervention, they missed 200. So, you know, it's stories like that that are actually associated with data. The data doesn't have to be very sophisticated, but it has to be something that the payers will understand. They don't want, and the big key is the emergency room. They want the patients to stay out of the emergency room, because the conversion rate from patients going into the emergency room to being admitted is, depending on what hospital you're in, 60, 70, 80% in some cases, unless the hospital is full or you go somewhere else. So we have to have data. We have to have it. There's no option.
And I would add to that, we struggle a little bit with, how do we prove that our model is working? And so we're actually, our one clinic has been open now just over 4 years, and the other one just over 3. So we're still fairly young and just getting our kind of first, data to where we follow people over time. But I would echo what he said in terms of looking at ER claims. So we will look at some of our patients being the insurance company, really a part of the insurance company, where we can look at their claims before they started coming to our clinic and then after they started coming to our clinic. And then we can show the cost savings. So that's really how we show a lot of our work is, what cost savings have we provided for this cohort of patients. But I think there's a lot more that I would like to be able to prove, and I think we struggle as well with some of the outcomes. HEDIS metrics is another, I showed that our clinic, strives to achieve the HEDIS metrics, and the health plan does pay us for a couple HEDIS metrics. They give us like an incentive to the clinics. None of the ones that we follow for behavioral health are currently incentivized. It's the adolescent well-child checks and the 3 to 6-year-old well-child checks. But I think that's maybe a step in the direction that we need to be going, in that, perhaps in the future we can get insurance companies to incentivize more of the behavioral health metrics.
Can you say more about the HEDIS metrics? I don't know what that is.
Yeah, so it's a health information, I forget what HEDIS actually stands for.
Employees data information set.
There you go, Health Employer Data Information Set. And so for our clinic, for example, one thing that we looked at with our behavioral health and ADHD patients was they want, for these HEDIS metrics, they want your ADHD kids who you have started on a medication, a stimulant medication, to have returned within 30 days for a follow-up visit, because that in their minds, and I think everybody's minds, shows that that is good care for the patient, that they have come back to see you after starting the medicine. So that's the metric that they want, and so we looked at our data the first year we were open, and we were doing horribly. And so what did we learned that our patients were coming back in 45 days or 60 days. So what did we do? We shortened our prescriptions. We said, let's only give them 2 weeks at the first time, because we want to see them back really within 2 weeks. And then we also had one of our social workers start calling these families and reminding them of their appointments. Those simple things increased our HEDIS metric above the kind of national standard. So overall, it's like a nationwide set of standards for various conditions.
that is determined by whom? Which body?
It was originally, I think, a consortium of some government entities, but mostly health plans and large employers. Certainly not for the benefit of the patient. I don't think any patients were involved in that.
My question's for Dr. Gordon. I was wondering what the challenges are, or if you'd considered expanding the clinics into the HISD system, and what it might look like to integrate into public schools versus the charter school system. Just I don't know much about the difference.
Actually, we're in talks of an expansion into HISD. I think that historically there was just less to navigate within the charter school system, but HISD has reached out to us recently, and so we're hoping that we can expand there as well.
HISD is one of the biggest school districts in the country, so it's a big,
Yeah, a big commitment.
yeah. And so, yeah, so we started with, KIPP and then Yes Prep, and just kind of tried to not, again, limiting risk, not bite off more than we can chew and make sure it's successful. I also, earlier when I was talking about behavioral health consultants, we have that in some of our clinics. So we have 14 freestanding clinics. And so we don't do that in the school-based clinics. We have the model that Dr. Gordon talked about. But Dr. Gordon also mentioned wishing that we had psychiatrists in more of the school-based clinics. And we actually used to have psychiatrists in more of the school-based clinics. And it again ended up being one of those volume and can you stay full and can you, keep it financially feasible. So there's one campus where we have a psychiatrist there 1 day a week and she's very busy. There were some other schools where we had psychiatrists, and despite the student body and the perceived need and thinking that they could keep us busy, they couldn't. And interestingly, as a federally qualified health center, laws and bureaucratic rules don't allow us to be able to bill for telepsychiatry. So, we would have to do some like half day at one school and half day at another school when you're driving across town, and we can't, telepsychiatry would be a good way to be able to get into lots of campuses, right? You can see a couple of kids at one school, a couple of kids at another school, but thus far, we've not been successful in getting that paid for. So we see a lot of, our psychiatrists see a lot of the KIPP and Yes Prep schools like at our clinics. And then once they get attached to us, we've actually, I see some KIPP and Yes Prep kids who are at the campus where we have a psychiatrist and they don't want to switch psychiatrists. They'll make the drive. But our appointments are less frequent. But for therapy, that's more frequent, or for nurse practitioner visits that, there's acute things during the day that come up. I mean, it's really, really nice to have those services.
So when we had all that psychiatry, I wasn't overseeing the program, and I'm overseeing it now, so I can get over it.
So Teandra talks to me occasionally about having more psychiatry at the school-based clinic. So we all want that. We just have to make it work. Other questions?
Hi, I'm Buzi, and I'm with the Berotine Clinic. So I'm very familiar with the school-based model, and I'm also familiar with the challenges. So I was wondering, how do you get integrated in the schools, Dr. Gordon, yeah? Anyway, how do you get integrated in the school themselves? Have, social workers, on campus. So how do you create, a shared vision, for like really addressing the needs of kids? And then also, do you provide family planning services on campus as well? I was curious about that.
We do provide, we just kind of got permission to do that recently at the school system, and we went in with that at the Yes Prep school system. So we do provide family planning. I think that we come in, and so the school counselor's role is kind of to serve all the student population, and then they kind of refer to us those specialized kids that need services, and so we just try to join in that vision and try to let them feel as in charge as we can, and I think that really helps the relationship and the collaboration. And so they're a large part of behavioral health is of our referral source.
There were some initial bumps in some of those relationships that Teandra was talking about, which before we had this model and we were first coming into the first school, some of them were like, what are you doing? some turf things, and or is my job going to be at stake? And once it was clear that we had separate roles where we could serve the kids in different ways, but we were there for kind of higher levels of care that they didn't have the capacity to provide just because they're serving so many kids and have other things on their plates than doing counseling or therapy. I think that helped. Us become a more gelled team. Other questions? Sure.
So I was really curious about, and this is for everyone. So what is your vision about as a community creating a shared vision for integrated behavioral health and creating a collective impact? So what do you do from your own organization to work with others in the community to really create collective impact? Well, this is, I believe, the only way we can make a difference in our communities.
I think for us, we are part of I think we have a packet, the Green Cheese and School-Based Health Collaborative. And so that's a big collaborative of behavioral health people who are in the schools from all over the city and surrounding areas. And they come together for monthly meetings, educational topics, kind of networking and sharing ideas. And so we're a big part of that, and we continue to kind of collaborate with people from other school districts and from other agencies and from other clinics to make sure that we're on the same page and moving in the same direction regarding our form of integrated.
Yeah, and I would echo from our clinic side, we can use a lot of the successes of the health plan. So, they have a lot of community contacts, and so we will often have a joint Christmas party with the local YMCA, or we will have some of the local schools will go out and speak with their school nurses or with their teams at the schools. And so I think it's just, getting your face out there and going to meet who it is that's in your community. And I think that's important. And we've met as well with some of the people in the Greenspoint area and kind of like the city center, shall we say. And so it's hard. It's a lot of kind of extra work and energy, but it's very important.
And as Representative Coleman stated, Texas is 48th in the country in all sorts of different metrics in healthcare. And McGovern being a research-based institution, we're also part of a statewide UT Health initiative, which if it actually rolled out the way the Regents in Austin anticipated will be able to provide service to huge numbers of Texans. So the idea of having a behavioral health collaborative, and this really is our incubator here, is something that we expect and anticipate would be able to be modeled sequentially and scaled throughout the rest of the state of Texas. So we're looking both locally as well as across UT Health as a state entity.
A lot of these services are really integrated for people that are low income. How do you see integration working for people that are using their private, third-party, regular insurance?
Not all of our
Out
clients
there,
are.
because I mean, we've got these great practices there, but probably a lot of people in this room are piecing together their specialists and going here and there, and we don't have this type of model, at least that I've found, for the majority of the population.
Well, I'll jump into that one since we looked at that as well. So not all the UT 18 community-based clinics that UT has are in federally underserved or even close to federally underserved areas. In fact, we have a clinic in Clear Lake, and 99% of the population there has health insurance. It happens to be the busiest of all the UT sites. They see 40,000, 42,000 patients a year, and have all the behavioral health product there as well. And it's incredibly popular. In fact, it's probably easier to sell to that population than to some of the population that just doesn't quite trust us yet. So you're right. It has to be done across the entire spectrum, not focusing on simply one group of folks. That's why we take the idea of the population health model very seriously. We try to be really agnostic with regards to income, unless the income presents a problem with accessing care, then we're all about our financial counselors.
Thank you everyone for speakers.
One more question.
So, I know I keep going back to the money, but, so SQHC money is also coming from CMS ultimately, right? Like, and the Texas Children's Health Plan is ultimately coming from CMS, and so is District Nate, right?
Right.
So, I mean, I just want to point out, like, kind of a nice lineup of, like, 3 beautiful experiments by our government, right? And how to fund the novel healthcare system. And, so when we look at the pros and cons and the advantages and disadvantages of each one, it'll just be interesting to see ultimately, I guess it'll take some years to look at the outcomes and see how they all line up. And ultimately, for myself, as a provider, I'm hoping that all 3 survive because we just need more care.
No, I think you're absolutely right, and that lends itself to discussion on the value of having 3 different approaches. When the government probably pays at the end of the day, if you include all in, 70-75% of all healthcare costs in the country. Leaving it up to the government, we wouldn't have 3 different models or 10 different models. So if we don't do it, it's going to be done to us. And these 3 models, although they share a lot of commonalities, are different enough that I think can stand alone and say, hey, this is what we've been allowed to do with the money. Keep sending the money. Don't tell us exactly how to spend it.
I mean, the struggle is not new, right? The struggle is between spending or saving money now versus spending or saving money later. So, it's on us to prove that some of these models save money. If you increase access to care and more people are getting more services, it costs more money under the fee-for-service system. But if we're preventing hospitalizations or worsening, or we're intervening when people are kids or teenagers, and we prevent longer-term sequelae, we save money in the long term. Unfortunately, our government and insurance companies don't always look years ahead. They're looking quarter to quarter, right? So, I mean, that's the fight that we're up against. Is we have to do with what we have to prove that these concepts work. All right, Martin, thank you guys for your attention. Thank you to
So thank you again to our speakers and to all of you attending, and for your comments, for participating in this fantastic marketplace of ideas that we've had tonight. In front of you and also in the Senator Taylor was a lot of important paperwork that we think we would like some help with. For those of you who are not familiar with Doctors for Change, there's this little brochure that in fantastic detail talks about just everything Doctors for Change does, and also how you can get involved beyond just our mental and behavioral health efforts. I know that our Human Trafficking Committee, our Healthy Eating and Living Committee, our Access to Care, Women's Health, and Immigrant Health committees can all benefit from your support in whatever little ways that you can. Moving forward tonight, in front of you is also this advocacy action plan. What are the immediate steps that we can do from tonight to make sure that the fantastic ideas that we've learned tonight and shared with each other tonight stick around and can be shared around? Some ideas include sharing this with your individual organizations or your clinics to see what sort of best practices that we've shared tonight can be integrated into your specific clinic. And since we're sort of in the legislative off-season, I think that it's important to keep this momentum going, this sort of momentum that Representative Coleman alluded to. We want to keep this moving forward so that in 2019 we still staying strong, and also make sure that the 3 different approaches that we've heard tonight continue to thrive and to continue to grow, and that hopefully there'll be more folks using their sort of practices and adding their own ideas to the ideas we've learned tonight. The little half sheet is a little sort of evaluation form for our forum tonight, in case you had any ideas or some feedback about how this went tonight, that we can incorporate your feedback to make our next set of events even better. On the back of the agenda for tonight's program, there's a couple of other DOC events upcoming, including one next month on maternal health, on November 8th, right in this location as well, and some other important DSC events, like the leadership meeting. You don't have to be a DSC leader to come to this meeting to learn about what we do. And finally, the Senator table is a flyer for our DSC silent auction and winter social that we think is just a fun event for all of us to get together, but also meet other members of the community who are passionate about improving the healthcare of Houston's and Texas at large. So thank you all so much to our speakers for coming out and sharing their ideas, to all you all for coming here and creating such a fruitful and lively discussion. We hope to see you all at our next DSC event soon. Thank you again. Have a good night.